access, but on my unit, we had to check both. We needed to make sure that before they left, we had a baseline, and then when they came back, because they might come back and it might be weaker, and the other stronger, so you just always want to check both of those pedal pulses. What else do I want to? Oh, when anybody goes in for any type of contrast procedure, so any procedure that involves contrast, that could be a cardiac cath, a nuclear test, might be some sort of MRI. Does anybody know what allergy we need to ask or to see if they have? 100%. So cardiac cath, we need to make sure they do not. Does anybody know the name of the med that we give them to counteract the allergy? Say it again? Nope. Well, they are going to get Benadryl, but that's like, it's actually a steroid. What?
How would you answer that question?
I like the way you turned that. Ro, what did you just say?
I said, I think I remember Miss Paul saying it, but I don't remember the name.
We definitely like it.
I'm pretty sure I just heard you say the name.
What was the question?
What's the name of the steroid to counteract a contrast allergy?
What
Dee
is
Dee
her-
said.
Dee, what'd you say?
I said prednisone or the Metamorphosis.
Yes, come get a prize. It's Medrol, Medrol, and it's also called methyl, she said meth, the M1, methylprednisolone is the generic of that, but it's Medrol. And just so you guys know, and I don't know if Miss Dawn told you guys about this, it's 2 pills, it's only given in 2 doses, it's usually given 12 hours and 2 hours prior to any contrast procedure. And when the patient arrives in the APU, the ambulatory procedure unit, that's usually when they're given Benadryl. Just as a precaution in case there is like hives or anything like that, but it's the Medrol, that steroid, that actually will bypass that patient from actually experiencing the anaphylaxis to contrast or to shellfish or whatnot. Okay, so if we are doing a cardiac cath and we're going through the femoral artery, what are we checking? Say again?
Fetal pulses or
Fetal pulses. Yep. Fetal pulses, peripheral pulses, they're interchangeable. What kind of position do you think we want this patient to be in? Do you think we want them in high Fowlers? Or do you think we need them to remain flat?
Remain flat.
100% flat. How long do you think they have to lay flat for?
6 hours.
It is 6 hours. Who said it?
Jen.
Back here.
All right, well, Nerd, you and Dee Dee can come up and get your prizes whenever you guys feel like you're done taking notes. What'd you say? Fair enough. Fair enough. Okay, are we doing, let's say they're back on your unit, you just get them. How often are we doing vital signs?
Every hour.
15.
For the
First
first
hour,
hour, right?
15.
All right,
And
start again, because there was like, I think you guys said it, but there was like a bunch. So first hour, Q15 first hour. And then what about for the next 2 hours after that?
an hour.
It's a half hour. So it's Q15 for the first hour, Q30 minutes for the next 2 hours. And then every hour until they're stable. All right, so if we know that we go in femorally, right, and we're not putting them in high Fowlers, why are we not putting them in high Fowlers?
Pressure on the front.
Right, like, so they're going through, we're gonna call it the groin, right? So if we have to lay him flat for 6 hours, tell me why we're not pinching.
Too much pressure.
100% too much pressure. Okay, so then does my leg have to remain extended and my hip kind of have to remain extended for the 6 hours, or can I flex it?
Straight for the 6 hours.
Keep it straight.
Yes, we want to keep our leg
A knee movement.
and our hip on that side, whichever side they go in. We want to make sure that it's just extended for that amount of time. They're not going to brace it, they're not going to do anything, it's just like up to us to educate the patient that it has to remain. What do you say?
They'll put the stick here on, like if they go through with this.
Yeah, they'll
Like
put
a
that
box.
beautiful bracelet tourniquet on, but sometimes they'll end up doing, it's called a fem pop, which is like this really great gadget that, I don't know, either a doctor or a nurse came up with, where it's like a baseball, and it puts that pressure on the site so that it's acting almost like a tourniquet. And all you have to do is just crank it, almost like if you were to do an old school tourniquet, you like crank the stick, and you crank it, and that is what puts the pressure like on that point. When they have a fem pop on, they're not looking to flex anything, like they don't even want to move, because it's just like somebody is pressing it. Does anybody know what the highest complication of a cardiac cath is? It's not super serious, but I mean, it could create pain for the patient. Say again? It could cause pain. No, this is like the most common, that's all.
Is it a nerve thing? Where they can make a nerve going in?
No, believe it or not, it's hematoma.
Didn't just.
Oh, yeah, she's been saying
She's
you
been
were
saying you
talking
were
about
talking
her.
soft, like you wasn't sure.
Damn.
Yeah.
So it's a hematoma. What'd she say?
That's surprising, it's okay.
Yeah, it is, but, you know, maybe she could use her outdoor voice.
Okay.
Okay, thanks. So it's a hematoma. When we think of like a hematoma, we think of a bruise, right? We kind of just think like different colors and, I don't know, there's like really no kind of race to it. The hematoma here is gonna start to produce a solid mass. So it could start off the size of a golf ball, it can slowly increase to a baseball. It's up to the nurse, right? When we're going in, every 15 minutes for the first hour, we need to be checking that site, right? It's up to us to be checking for bleeding to make sure like, hey, he's not bleeding out. If the nurse is like, he seems pretty stable, I'll check him every half hour, and then now there's a hematoma. The only way to get rid of that hematoma is to massage it out. So on top of a patient just having arterial access with like a catheter, now the only way you're gonna get this knot out, which let's say at this time is like the size of a golf ball, is to literally press and rub it out of them. They are pissed. They are beyond pissed. So every 15 minutes, we need to make sure we're checking the site, checking for bleeding, checking for hematoma. If we do start to see some bruising like around, let's say where the bandage is, it's fine, we can lift the bandage, right? We can see what's going on. If there's like a fem stop on, there's no hematoma, period. It's just not gonna happen. There's so much pressure of that ball that's like already there going in that it's just not gonna happen. The issue why they end up with a hematoma is because the pressure that was applied in the procedure itself wasn't enough. It may have stopped the bleeding, but it might have stopped the bleeding at the site. It didn't stop the bleeding internally. So that's why when you start to get this baseball and we have to like massage it out, we have to make sure that all that blood that has now formed, make sure that we break it up and that the body is able to reabsorb it, or really we need to make sure that it is going to be able, to go through our circulatory system. So, the arm tissue, leg tissue, whatever, we need to make sure that, we get it massaged out enough so that the patient doesn't stay an extra day or two because of a hematoma. The majority of hospitals is, it's all about money, right? I hate to say it, it's a business. If your patient is staying because of a complication that could have been prevented, that money is now being taken out of. In this instance, that money for them to stay, even though insurance is covering it, let's say it's 200 grand, is now coming out of the cardiology's budget, not the hospital's. So now you can see why people are gonna be very strict in making sure that you're checking every 15 minutes, the vitals are okay, there's no hematoma, right? Like, bless, if somebody ends up with a complication where the stent clots again, let's say they got a stent and it clotted, like that's not a complication. That's somebody with very aggressive plaque, let's say, buildup that in that one spot where they're gonna have to actually put a stent in that is medically treated so that the medicine itself that's on that stent will keep the blockage away. They like make these stents now that have that. Yeah, oh, something along that line, yeah. But it kind of dissolves the plaque buildup itself, as opposed to preventing like a blood clot, you know, and breaking the blood up. Okay, does anybody have any questions on a cardiac cath? No. Okay. Can somebody tell me, without the bundle branch blocks, Kristen, not you, what is the conduction of the electrical impulses of the heart? We're going to start with the SA node.
Yeah, oh, you mean the passage?
Yeah.
The SA to the AB, to the bundle of his. Then you have the right and left.
Okay.
And then the package again.
Perfect. Would you like anything?
Later.
Okay.
Until later.
Okay, so we are going SA node, AV node, bundle of his. Then you're going to go left and right, bundle branches. And then you're going to do your Purkinje fibers, which is PURKINJE. And then that's it. So, does anybody know what the normal heart rate is for, like, to be sinus rhythm? Yeah. Can anybody tell me what the SA node does?
It's a pacemaker.
It is the primary pacemaker, you're right, thank you. It is the primary pacemaker of the heart, which means if you have an active SA node that fires, then your heart rate is 60 to 100 beats per minute. Okay. Somebody want to tell me about the SA node? AB, oh, I'm sorry, AB, sorry. Yeah, anybody want to tell me everything all over again? Yes. You can try.
I know the AV, the SA node, it conducts to the AV node between the atrium and the ventricle, and that's what helps them to contract and relax.
Very true. What happens if the SA node shits the bed?
If it what?
If
the SA node doesn't work anymore.
Oh, then the AV node, it doesn't function properly.
But so if the SA node,
It tries to compensate, but it.
yes, the AV is going to try to compensate. However, do we know what the normal heart rate that the SA node, that the AV node will pop out? I thought I had something for you guys for this. So like our SA node is 60 to 100. Does anybody know what the AB is?
It would be lower. Would it be lower?
It is 40 to 60.
Yeah.
I see. Okay. How did you know that? What'd she say?
She got the thing in front of her.
Here.
Being honest.
What thing? I gave you guys something with it?
Oh my God.
I didn't think I did.
She printed out.
Too busy memorizing it in order.
Oh, by the way, while we're on the topic, are we gonna get like, papers?
What kind of papers?
Outlines?
Like,
You want an outline?
yeah, like.
Yeah.
I just wanted to ask.
You definitely are.
Okay,
100%.
Oh, no.
What PowerPoint is that in?
Yeah.
Oh, wait, it's not on this side. No, no. I guess I just said a good guess.
I was gonna say, I thought it was like in a much further PowerPoint, like the breakdown. I was like, God.
Janice said 40 to 70, so I was like,
I
no,
thought it
she
was
said
from
50 to 70. I said,
Oh, I was like, I really thought you printed up like chapter 25 or 26. I was like, my God, you guys are overachievers.
I know it was less. but-
Whew. All right, so it's 40 to 60, right? And the name for our AV node is our gatekeeper. So this technically is, if we end up with no SA node and no AV node, we have no heart. Like there's no natural heartbeat going on whatsoever. And you're right, it does fire between 40 and 60. Your bundle literally is just the fork in the road where the blood gets split into the right or left bundle branches. What will happen is that somebody will come in for a cardiac cath and you know what'll happen? Somebody will get an EKG. On the EKG, they're gonna see that they have a bundle branch block. Having a bundle branch block is then gonna send them in, you okay? You have a bundle branch block? Okay. It's going to send them in, and usually they're gonna need to get stented. And probably some heavy blood thinners, like apixaban, probably for the rest of their life. Bundle branch blocks are, here. The bundle branches themselves are so small that recurring blocks happen. So that's why you're gonna be on the blood thinner for the rest of your life. And I like printed out my notes for you guys. I was like so prepared. What else? So if we do not have any blockages in our bundle branches, those are just used technically to send down our impulses into each ventricle. And then our Purkinje fibers are your final stop for the delivery of impulses to the ventricle tissue. So all of that to say that this whole conduction pathway from your SA node to your Purkinje fibers is what they call like your EKG complex. Has anybody ever seen an EKG strip or done an EKG?
Yes.
Okay. Has anybody broken down an EKG heartbeat to where they were able to see your PQRST wave? Okay, so this conduction pathway is what's responsible for that, from your P wave all the way to the end of the T wave. It's this process that formulates that for you. Okay, when we go to EKGs, I think that's when I'm gonna break it down a little bit more, but let's see what chapter 22 is. Does anybody have to pee? What'd you say?
Hypertension.
Okay. Anybody want to pee, stretch their legs, do anything like that? It's only 31 slides. We'll finish this and then I'll do maybe some hypertension questions and then send you guys on your way. Does anybody have to, or just need like 5 minutes? Stretch it out. Give it a little stretch, guys, because I know 3 hours is a long time. A long time.
I know, I'll do that.